I am Ziad Ghazal from the Division of Cardiology. I will be giving you three presentations on congestive heart failure. The first presentation today, I will focus primarily on the pathophysiology of congestive heart failure. In the second presentation, I will be talking about congestive heart failure presentation and management, all the way to cardiogenic shock. And in the third presentation, I will be discussing the topic of cardiomyopathies. First, let's start with some epidemiology. The prevalence of heart failure among adults in the US increases with age for males and females, as you see in this graph, with a sharp rise in the prevalence from the age of 60, reaching a prevalence of 12 to 13% for patients 80 years of age and older. Heart failure is a major cause of morbidity and mortality worldwide. The overall prognosis for patients with heart failure is improving due to treatment of risk factors and increased use of guideline-directed therapies. So what is heart failure and how is it defined? Heart failure is defined as cardiac dysfunction leading to reduced cardiac output. Heart failure can also lead to elevated pressure in the heart, referred to as intracardiac filling pressure. Heart failure can also lead to inadequate oxygen delivery to the peripheral circulation. All these effects can occur at rest or during stress or exertion. To put it simply, heart failure results in lowered cardiac output with increased pressure in the heart and subsequently leading to insufficient oxygen delivery to the periphery. What can cause cardiac dysfunction that results in reduced cardiac output? It is any structural or functional impairment of ventricular filling or ejection of blood leading to dyspnea, fatigue, and fluid retention. So now I am introducing the concept of problems with ventricular filling, which is cardiac diastole, and or problems with ventricular emptying, which is cardiac systole. I will expand on this during my presentation, but keep in mind that in most patients, abnormalities of systolic and diastolic function coexist. In terms of signs of heart failure, the classic ones are elevated jugular venous pressure, pulmonary crackles or pulmonary edema, which I will also expand on to make sure you understand how to tie signs and symptoms to the basic pathophysiology of heart failure. As I mentioned in the previous slide, there are two major types of ventricular dysfunction. One that has to do with cardiac emptying, therefore it has to do with impaired ventricular contraction that we refer to as systolic function. And the other type is diastolic dysfunction that has to do with impaired cardiac filling. This brings the notion of ejection fraction. And it is important to understand what is ejection fraction, how it is calculated, and how it can differ in systolic dysfunction and diastolic dysfunction. So now let us expand on what is ejection fraction. So as you know, with each heartbeat, there is ventricular systole and ventricular diastole. With ventricular systole, that's when the ventricle contracts. In case of the left ventricle, when it contracts, the blood is pumped out into the body, and ventricular diastole follows, where the left ventricle relaxes and fills up with blood from the pulmonary venous return. So how then do we calculate the ejection fraction from systole and diastole? The ejection fraction measures the amount of blood the left ventricle pumps out to the body with each heartbeat. And the calculation of the ejection fraction is simply the ratio of the amount of blood pumped out in systole to the amount of blood in the chamber in diastole multiplied by 100. It becomes a percentage. So it's really the percentage of the amount of blood that is pumped out with each heartbeat. But now remember that the amount of blood pumped out in systole is referred to as the stroke volume. Okay? It's the amount of blood that's pumped out from the left ventricle in systole. And in green, in the denominator, the amount of blood in the chamber in diastole is also referred to as the end diastolic volume. Okay? So let me give you an example of an ejection fraction. Let's take an example of where the end diastolic volume is 110 milliliter of blood. That's in end diastole when the left ventricle fills up with blood. And then let's say it ejects 55 milliliter of blood in systole. So the ratio and in percentage, the ejection fraction is 50%. The normal ejection fraction is 55 to 70%. It is very important when we explain the ejection fraction to our patients and share with them their ejection fraction that we tell them that the normal ejection fraction is not 100%, so that they don't freak out. If you tell them, your ejection fraction is, let's say, 60%, and you don't tell them that the normal is not 100%, they'll think that their heart is pumping at a value of 60% compared to a normal of 100%, which is wrong. So you need to explain to them what a normal ejection fraction is. Now, another formula that you need to understand and memorize is the cardiac output, which is the product of stroke volume times the heart rate. As an example, a stroke volume of 60 milliliter per systolic ejection and a heart rate of 70 beats per minute gives you a cardiac output of 60 times 70, which is 4.2 liters per minute. So this is how we calculate the cardiac output, stroke volume times heart rate. Here are some causes of heart failure that can affect ventricular filling, such as chronic hypertension. Hypertension can initially cause the left ventricle to hypertrophy, resulting in diastolic dysfunction, which I will elaborate on later. A heart attack, on the other hand, can cause myocardial damage with a drop in ejection fraction and therefore a reduced cardiac output as a subsequent effect. Other causes of heart failure can include diabetes with its effect chronically on the coronary circulation and coronary atherosclerosis, valvular heart disease, the cardiomyopathies, which I will elaborate on in my later presentation, infection, viral myocarditis, for example, congenital heart disease, cardiotoxic drugs, which can depress the left ventricle, alcohol, which is also a myocardial depressant, which obviously will have its effect on the heart if it's abused in large amount chronically. And there are obviously other causes of heart failure. So now let's analyze the sequence of events starting with cardiac dysfunction resulting in reduced cardiac output. Since the heart is not able to pump out the blood efficiently, the pressure in the heart starts rising. And this elevated intracardiac filling pressure on the left side is referred to as the increase in left ventricular end diastolic pressure or left ventricular diastolic volume. It is the pressure that can be measured in the left ventricle at the end of the diastolic cycle, meaning when the heart is fully filled. This increase in the left ventricular and diastolic pressure will cause a rise in the left atrial pressure, which in turn will cause a buildup of fluids in the lungs, which is referred to as pulmonary edema, as you well know. Let's take this a step further. A reduced cardiac output will cause an increase in left ventricular and diastolic pressure, resulting in an increase in left atrial pressure, and therefore an increase in the pulmonary capillary pressure. This will cause pulmonary edema, which will result in a rise in pulmonary arterial pressure. There is a common terminology termed backward failure, whereby the rise in pulmonary arterial pressure may cause an elevation in the right ventricular pressure and in the right atrial pressure. The elevation in the right atrial pressure will cause the central venous pressure to be elevated, translating into an elevated jugular venous pressure and peripheral edema. You can also have hepatomegaly and ascites. This is now referred to as right heart failure. Remember that the most common cause of right heart failure is left heart failure, but right heart failure can occur without left heart failure, such as when you have problems with the lungs, primary problems with the lungs. So therefore, right heart failure can be secondary to lung disease or primary pulmonary hypertension. To summarize, when there is left ventricular dysfunction and failure, this on the one hand will lead to pulmonary congestion and pulmonary edema, but it can also result in right ventricular dysfunction and right ventricular failure. So you can have right ventricular failure from primary causes affecting the right ventricle or lung disease causing pulmonary hypertension. Right ventricular failure causes, in turn, liver congestion and possibly liver failure and ascites, as well as systemic congestion and peripheral edema. The overall low cardiac output together with the systemic congestion can result in low kidney perfusion and therefore renal impairment. Now let's go back to the ejection fraction, since heart failure has been categorized according to the range of ejection fraction. So it's important to understand in general when we talk about heart failure how we use the categories of heart failure according to ejection fraction. Heart failure with a reduced ejection fraction, also termed HFrEF, is when we have a left ventricular ejection fraction or of less or equal than 40%. On the other hand, there is heart failure with mildly reduced ejection fraction, whereby the ejection fraction is between 41 and 49%. And there is heart failure with preserved ejection fraction, termed HFpEF, with an ejection fraction of equal or higher than 50%. And while it is easy to understand how a reduced ejection fraction can cause a drop in cardiac output, let's try to figure out how a preserved ejection fraction can cause a drop in cardiac output through the following examples. This is an example of a normal heart where the left ventricular end diastolic volume is 110 milliliter when the ventricle fills up in normal diastole. This normal ventricle then ejects 70 milliliter of blood during systole. This normal heart has a left ventricular ejection fraction of 64%, as we learned how to calculate the ejection fraction. The cardiac output for a heart rate of 70 beats per minute and a stroke volume of 70 milliliters calculates at 4.9 liters per minute. So that's an example of a normal heart function. Now, in a ventricle with reduced ejection fraction, caused, let's say, by myocardial damage from a heart attack, the heart would still fill with 110 cc in diastole, since there is no problem in diastolic filling. But let's say that in this example of a reduced ejection fraction from a heart attack, the heart is only able to pump, say, 44 milliliter of blood in systole because of the systolic dysfunction. Then the calculated ejection fraction is reduced to 40%. The cardiac output for the same heart rate of 70 beats per minute, but a stroke volume of 44 milliliter, calculates at 3 liters per minute. When you have diastolic dysfunction, the heart does not fill properly during diastole. If you have heart failure with preserved ejection fraction, this means the ventricle during diastole fills up with only 70 milliliter of blood in this example. Because the filling is reduced, the stroke volume is also reduced, but the ejection fraction is also reduced. In this example, 44 cc's of a stroke volume from a total volume of 70 cc's or milliliters in diastole gives you an ejection fraction of 63%. However, even though the ejection fraction is normal at 63%, the cardiac output is reduced. How come? The cardiac output, remember, at a heart rate of 70 beats per minute times the 44 cc's ejection during systole of this stroke volume gives you or calculates a cardiac output of 3 liters per minute, which is reduced even though there is no systolic dysfunction. Now let's turn to some more detailed physiologic principles. Let's start with the determinants of left ventricular performance. Left ventricular performance depends primarily on preload, on myocardial contractility, and on afterload. Now let's expand on all of these a little bit. Preload is defined as the particular stretch or length of the left ventricular myocardial fibers during diastole before the ventricle ejects the blood. The volume of blood at end diastole is a measure of preload. The Frank-Starling law, it's a very important law to understand. It establishes the relationship between ventricular end diastolic volume, which is a measure of preload, and ventricular performance, which is a measure of stroke volume. The higher the end diastolic volume, the more the myocardial fibers are stretched. And the more they are stretched, the more tension and the more force generating contractile power. But this can occur up to a point. This is a schematic representation of a sarcomere, where actin, shown in black, are attached at the Z-band. Myosin is shown as the thick maroon bands. The more preload, the more sarcomere stretch and tension that generates more contractile force. This is seen in position 2, right here and right here, and position 3 that you see here and here. So with these positions, the more preload, the more sarcomere stretch and tension that will generate more contractile force. So the more you stretch, the more you will increase the force of contraction. But when there is excessive stretching of the sarcomeres, then this will not result in more contractile force. So look at position 1 right here. It shows a sarcomere at maximum stretch, as can occur in very high preload or left ventricular volume overload. Actin and myosin can no more interact and there is no tension. That's when the myocardial contractile force drops. Therefore, increasing sarcomere length up to a point increases the degree of overlap between actin and myosin filaments for force-generating cross bridges, and this enables increased tension development and a higher contractile force, but this occurs up to a point beyond which this will not occur anymore and the ventricle will start failing. Okay, now this concept takes us to the Frank-Starling curve. It's a very important curve to understand. It depicts cardiac output as a function of left ventricular end diastolic pressure or left ventricular end diastolic volume. On this graph, the x-axis, you have the left ventricular end diastolic volume or pressure, and on the y-axis, you have the stroke volume or cardiac output. Remember that cardiac output is stroke volume times heart rate. So the Frank-Starling curve basically depicts what we were talking about in that the higher the end diastolic volume, which is the preload, the higher the LV EDP. This causes a stretch in the myocardium, as we explained earlier, and this increase in stretch will in turn cause what? An increase in cardiac output, which is known as the Frank-Starling mechanism. Take point A, for example, on the curve, which represents a healthy patient with a normal heart. But remember that there is a limit to this increase in cardiac output. With increasing amounts of preload, the resultant increase in cardiac output is reduced as the curve flattens out. The lower curve, labeled heart failure, belongs to a patient with systolic heart failure and therefore systolic dysfunction caused by a weak heart muscle. On this curve, For any given point on the preload x-axis, the stroke volume or cardiac output is lower compared to the normal heart. Initially at point B, an increase in preload leads to a compensatory increase in cardiac output, although this increase is less than what we normally see in normal heart. As the patient's heart failure increases, as indicated by point C, then the stroke volume only increases slightly for the increase in left ventricular and diastolic volume. Eventually, this curve becomes flat and even downwards as the heart muscle decompensates and the compensatory mechanisms are exhausted. At this point, increasing left ventricular diastolic volume and increasing left ventricular, therefore diastolic pressure, will lead to pulmonary congestion with a depressed cardiac output. Now let's talk a little bit about afterload. Afterload is best explained as the impedance that the ventricle meets during ejection of blood. It is the pressure that the heart must work against to eject blood during systole. It depends on changes in ventricular volume and wall thickness. It also depends on changes in aortic pressure and systemic vascular resistance. In the normal heart, stroke volume is only minimally altered by changes in afterload. But in a compromised heart, elevation in systolic pressure reduce the ventricular stroke volume at any given diastolic volume. This graph from UpToDate actually depicts afterload or systemic vascular resistance on the x-axis and stroke volume or cardiac output on the y-axis. It shows how increasing afterload has little acute effect on the normal subjects represented in the top red line. But in patients with ventricular dysfunction, increasing afterload becomes progressively more limiting on cardiac output. This is why lowering afterload when you have ventricular dysfunction slows the rate of drop of ventricular function. So this again summarizes the parameters that can influence stroke volume and therefore cardiac output. So primarily it's the preload, contractility, and afterload. And it's important to keep all of these in mind. Now let's talk about heart failure and the initial compensatory mechanisms that take place to help the heart maintain normal function. So let's here take the example of a patient who suffers from a primary event leading to heart failure. It may be sudden, such as an acute myocardial infarction, or more gradual, such as with chronic pressure or volume overload, as if we take the example of aortic stenosis or chronic hypertension. Compensatory mechanisms are initiated as a result and occur as the failing heart attempts to maintain adequate function. And patients may remain asymptomatic thanks to these initial compensatory mechanisms for prolonged periods of time. So what are those important compensatory mechanisms? The Frank-Starling response that we discussed earlier, and to remind you, this is when there is an increase in left ventricular end diastolic volume and left ventricular end diastolic pressure. The myocardial fibers are stretched, resulting initially in an increase in cardiac output. Then there are other mechanisms, um, neurohormonal, autonomic, and hemodynamic, as well as ventricular remodeling, which I will detail for you during this presentation. The key thing to remember is that these chronic adaptive changes, while initially beneficial, in the early stages of heart failure eventually turn to maladaptive and become counterproductive. Thus, continued progression of heart failure eventually leads to a drop in cardiac output and a critical reduction in blood flow to all vital organs. We talked about the Frank-Starling mechanism. Let's now talk about the neurohormonal, autonomic, and hemodynamic compensatory mechanisms represented by the activation of three systems. One of them is the activation of what we call the RAS system, the renin-angiotensin-aldosterone system. Another is the sympathetic nervous system. And another favorable compensatory mechanism is the natriuretic peptide system. Here's what happens in the early stages of a drop in myocardial function. Heart failure leads to a drop in mean arterial pressure, and the mean arterial pressure being the product of cardiac output and total peripheral resistance. This will in turn will lead to a stimulation of the sympathetic nervous system and release of catecholamines such as norepinephrine and epinephrine, which is all mediated through three receptors, beta 1, beta 2, and alpha 1. As a result, we get these compensatory changes, and these are favorable changes initially. The increase in heart rate, an increase in contractility, and an increase in vasoconstriction. And in the peripheral vasculature, there is the activation of the beta 1 and alpha 1 receptors lead to activation of the renin-angiotensin-aldosterone system, which causes vasoconstriction, sodium and water retention, and thirst. All of these will augment the mean arterial pressure. So all these resultant effects will be favorable: vasoconstriction, water retention, increased contractility will help maintain cardiac output and mean arterial pressure. Another parallel mechanism is when there is heart failure and a decrease in mean arterial pressure, leading to reduced renal blood flow and sympathetic activations. The kidneys then secrete renin, and renin then acts on angiotensin in the liver to make angiotensin 1. Circulating angiotensin 1 is converted by angiotensin converting enzyme, or ACE, in the lungs to angiotensin 2, which will lead to an increase in vasoconstriction and release of aldosterone and the release of norepinephrine. This will all promote sodium reabsorption, will stimulate vasopressin release, and as a resultant, there is an increase in contractility. The increased vasopressin causes vasoconstriction as well as increased water retention, and the overall result is again augmentation in the mean arterial pressure, thus counteracting the reduction in mean arterial pressure seen in heart failure. So again, all these are favorable results of these compensatory mechanism that will lead to restoration and augmentation of the cardiac output and mean arterial pressure that occur initially in heart failure patients. Therefore, when there is a reduction in cardiac output seen in both heart failure with reduced ejection fraction and heart failure with preserved ejection fraction, this leads to the activation of compensatory mechanisms that we talked about to redress the imbalance. We talked about two important systems that are activated in response to reduced systemic perfusion, which are the renin-angiotensin system, or RAS, and the sympathomimetic nervous system. The result of these compensatory systems are initially beneficial, but ultimately become detrimental, and that is why we refer to them as pathophysiologic responses. But there is a compensatory system, which is the natriuretic peptide system, which is a physiologic response to heart failure and continues to be beneficial. Let's then review the effect of the natriuretic peptide system, whereby the heart secretes natriuretic peptide in response to left ventricular stretching or wall tension caused by the heart failure. Natriuretic peptides have several actions. One, the downregulation of the sympathetic nervous system and the renin-angiotensin-aldosterone system. Two, they facilitate natriuresis and diuresis, and they also decrease peripheral vascular resistance. This all results primarily in vasodilation, where there is a reduction in aldosterone, in systemic vascular resistance, in sympathetic tone, and a reduced potential for cardiac fibrosis and cardiac hypertrophy. And due to the heightened natriuresis and diuresis, there is less sodium and water retention in heart failure. The result is improvement in heart failure. And this is a long-lasting result. Keep in mind that levels of natriuretic peptides, such as BNP or the beta type natriuretic peptide, these are released in heart failure and they are used in the diagnosis of heart failure. However, the effect of this natriuretic peptide compensatory mechanism system is not sufficient to counteract the effects of the RAS and sympathomimetic nervous system response. Now I want to help you recall these pathophysiologic mechanisms that we already talked about and put them side by side on this same slide. So in addition to the physiologic natriuretic peptide system, there is the pathophysiologic response caused by the renin-angiotensin-aldosterone system, or RAS. This response system causes an increase in aldosterone, in systemic vascular resistance, and in sympathetic tone. The result is vasoconstriction and sodium and water retention. Even though these effects are initially favorable, but on the long run, these will worsen heart failure in addition to promoting cardiac fibrosis and cardiac hypertrophy. The third system that is activated and that we talked about in response to a reduced systemic perfusion is the sympathomimetic nervous system. It also causes vasoconstriction. It increases RAS activity, increases vasopressin, heart rate, contractility, and the sympathetic tone in general. This ultimately leads to increased circulating blood volume, which will increase preload and increase the stroke volume and improve cardiac output, but ultimately this mechanism is also detrimental and causes worsening in heart failure. Now let's turn to the important concept of cardiac remodeling, which is another compensatory mechanism in heart failure. The chronic hemodynamic stresses on the heart lead to alterations in the size, shape, structure, and function of the ventricle in a process known as remodeling. As remodeling occurs, alteration in structure and function of the ventricle does occur, with changes in size, shape, mass, and volume. The heart becomes less elliptical and more spherical, and these initial compensatory changes in the form of geometric alterations initially are compensatory, but as the failing heart enlarges to increase ventricular volume, this leads to a greater stroke volume and higher cardiac output despite a reduced ejection fraction. Take the example of a normal heart that is subjected to chronic pressure overload from, let's say, uncontrolled blood pressure. Then myocardial wall thickness and overall ventricular mass are increased, as we said before, leading to left ventricular hypertrophy, which initially leads to increased contractility. As the ventricle continues to enlarge and the myocardium hypertrophies, this leads to increased wall tension and fibrosis, which eventually impair contractility. The long-term process of remodeling also leads to an increase in myocardial apoptosis. And on the long term, the dilated and remodeled ventricle leads to less effective pumping. And the remodeling process in heart failure, as it is progressive, and eventually it becomes actually detrimental. With heart failure, whether we're talking about HFrEF or HFpEF, mean arterial pressure and cardiac output are reduced, and this will trigger, as we explained, the neurohormonal compensatory mechanism and will trigger cardiac remodeling. The result is an increase in cardiac output through an increase in contractility and heart rate, and the blood pressure will be restored as a result of vasoconstriction as well as sodium and water retention. But these systems are continuously turned on, and that's what's important to understand, in order to compensate for the failing heart's inability to maintain normal cardiovascular hemostasis. The continued progression of heart failure eventually leads to a critical reduction in blood flow to all vital organs. And subsequently, as the body maximizes all of its vasoconstrictive mechanisms in order to attempt to redirect blood flow to these critical organ system, and as the body is retaining water, the heart will face an excessive volume overload and workload, which will only add to the hemodynamic burden of the failing heart. Thus, ventricular function will progressively deteriorate and a vicious cycle develops whose end result is progressive ventricular dysfunction and further deterioration. So to conclude this presentation, I want you to again remember the most important part of the pathophysiology, which that there are compensatory mechanisms which initially help the heart but ultimately become detrimental, and that becomes important in how we ultimately understand how to approach patients with heart failure and use the proper pharmacology. So with heart failure, there is this decrease in cardiac output that leads to an increase in left ventricular and diastolic volume and pressure that of course can lead to pulmonary edema. So in the early phases of the disease, there is this increase in filling pressure that will raise ventricular performance, and the body tries to maintain adequate blood pressure and tissue perfusion through these compensatory mechanisms that we've explained: the Frank-Starling law, the neurohormonal, including the RAS system and the sympathomimetic nervous system, and the natriuretic peptide system. But again, as the increased filling pressure persists, even as the compensatory changes are taking place to help the heart, but as the filling pressure persists, the myocardium will eventually fail and the cardiac output drops. My next lecture, phase 2 of the congestive heart failure, I will address for you the presentation of heart failure and patients and how to manage them.